Thank you very much to Jessica, to Ruth, to Nancy, to Alice. I'm delighted to be here, so thank you for inviting me. And just to pick up on where Karen ended, I'm just going to take a few minutes and tease out some of the state interests that the Supreme Court expressed in Carhart. And not to paint a gloom and doom picture, but my purpose is to suggest that unlike some of the conversations that happen internationally, where there have been perhaps a more nuanced discussion of some of the balancing of interest, the pregnant woman, the physician, the fetus, and guidelines proposed and introduced to try to wrestle with some of these ethical issues, that conversation really hasn't happened on a large scale here. And our worry is, as we reflected on the international experience in this paper that we wrote last fall, is that the anti-abortion rhetoric of this country could really co-opt that discussion in very significant ways. And that's not a necessarily pro-life, pro-choice type of statement. That is a reflection on what does it mean to have an impoverished discourse at this intersection. So in my short time, I just want to expand on a couple of the themes that Karen touched on, think about the constitutional questions as they relate to state interests, and I'd like to try to connect that analysis to some of the conversations we had yesterday about informed consent or the lack thereof, patient education and reaction and anxiety, and the clinician role in offering and explaining testing. So yesterday, Professor King mentioned several laws that are regulating abortion and impact either explicitly or potentially on testing and screening. And I wanted to just spend a couple of moments talking about what those laws say and what they do. And I'm going to use Oklahoma as my example because it is a fruitful ground for this type of regulation. And I can say that with some affection because I spend a lot of time in Tulsa. My partner's from Tulsa. So no offense to any Oklahomans, but your state legislature is active. So, and I'm from Florida, so, you know, I'm not casting stones. So first, the wrongful birth legislation. Oklahoma recently passed legislation that relieves physicians of liability in a wrongful birth cause of action if, quote, the act or omission contributed to the mother's not having an abortion. So that's a little bit distinct from legislation which about nine states have, I think, which ban all wrongful birth causes of action. So Pennsylvania, for instance, who says don't come to court, parents, and claim damages for the child's injury that you could have avoided through abortion. Oklahoma has actually done something a little bit different. It says if you have a wrongful birth action, you, physician, will not be liable for monetary or non-monetary damages, which is a step further because it carves out of otherwise possible tort action the role of the physician who, because of a claim that they wanted to avoid the terribleness of abortion, is insulated from liability. I think that Arizona has flirted with similar language. Other states are thinking about similar, are debating similar bills, Kansas, for example. And I think that says something about what the real motive for the wrongful birth cause of action legislation is. Oklahoma also has a recently enjoined ultrasound law, which requires physicians to perform either transvaginal or abdominal ultrasounds, and the statute actually indicates whichever is clearer. So if a transvaginal ultrasound is clear, then that's technically what should be offered by the provider, who will then describe the internal organs, the body parts, the members, the cardiac activity, and the dimensions of the fetus. And the other aspect of this legislation that's worth noting is that a woman may, by the provisions of this law, look away, but she must sign a certificate that says she is approved of and she can, and that the doctor followed all the legislative steps expressed in the bill. So, Oklahoma. Oklahoma also has a Paying Capable of Unborn Child Act, another very subtle title, which bans abortion after 20 weeks. A statistical reporting of abortion act. This is interesting because as an informed consent measure and in regulating physician conduct, the physician has to essentially fill out a form in which one aspect of this form is that they indicate what are the reasons for the woman's abortion. And two of those reasons are significant for our conversation. One is, mother, are you having this abortion for purposes of sex? And are you having this abortion because of a, quote, possible problem with the fetus? So that relates to something that Jamie King mentioned yesterday, the sex selection laws, which Oklahoma also has one, which prohibits knowingly performing an abortion because of fetal sex. And if we step outside of Oklahoma for a second, I think we talked a little bit about the 3 other states that have passed similar laws. You know, I think this really shows a interesting trajectory in state legislation because it's not only the will to start regulating for the reasons women have abortions, but it's also a reversal of the one-time trend that Karen mentioned, which is states like Utah, Maryland, and I just blanked, Utah, Maryland, and Texas, who explicitly provided for abortion later in pregnancy for reason of fetal anomaly. Well, that trend, I think, is being reversed. Texas, that ground is now under attack. Last year in their legislative session, bills were introduced to remove fetal anomaly as a ground for abortion. Likewise, the Tennessee law that Karen mentioned forbids the state program from funding any testing or any screening if it's for an incurable disease or a disorder that can't be treated in utero or after birth. So I just mentioned those quickly to suggest there is a whole basket of regulation and legislative activity that is not only reason-based, but is targeting reasons of non-medical abortion, non-medical trait abortion, and medical trait abortion. So in my few minutes, I'm going to keep an eye on the light. Can states do this? Well, Gonzalez v. Carhart, Justice Kennedy, the author of the majority opinion, who you saw in our slides, is the last word from the Supreme Court on the issue of abortion, and I think it says some pretty gloomy things about whether or not these laws may or may not be constitutional, and I'm going to argue in my last kind of few minutes that they potentially are constitutional under Carhart. Carhart upheld a federal ban on intact dilation and evacuation. I'm sure most people in the room kind of are familiar with the case and what the law did. In upholding the ban, the court articulated state interests that were important, at least balanced against the potential undue burden that the ban might impose upon women. In articulating the state interest, I think it really focused on 3. It's 3 or 4, and I'll think about 4 here today, and these have been the subjects of a lot of scholarly work. First, protecting the medical profession, something that Karen mentioned. I think wrongful birth statutes fit into this state interest. First of all, that you could think of them as a type of conscious clause, protecting the physician who doesn't want to provide abortion for those reasons, but maybe would provide abortion for other reasons. And I think it also is the protective stance of the Supreme Court who says we're going to protect physicians from engaging in what might be unethical conduct that they're not very good at policing. So the health exception. If we had a health exception in Carhart, we would force physicians to essentially fit these procedures into health reasons in ways that might not entirely be ethical all the time. Well, you could see a wrongful birth statute or something akin to that being upheld for some similar reason, right? We don't want to put physicians in this dangerous position of having to perform these abortions for unethical reasons. Protecting society. Here I think wrongful birth and the sex selection statutes really have a lot of resonance with this state ground, that we want to protect society from collective or aggregate decision making that might really hurt populations of people populations of disabled people. We don't want to further marginalize those populations by allowing people to terminate pregnancies on those characteristics. And I'll finish up. The third, protecting fetal life. I think the 20-week bans and the fight over whether fetuses can feel pain, those go directly to this idea of the integrity of potential life. And like the Carhart ban was gruesome, the procedure at the heart of Carhart was gruesome, the suffering that a fetus might feel could also warrant the kind of moral disapproval of states to protect fetal interest. And finally, and I think this relates really well to our conversation yesterday about anxiety and counseling, protecting women. So some of the best language in Carhart is about the regret that women will feel once they figure out what an intact D&E entailed. Well, interestingly, the conversation we've had about the anxiety women feel, the lack of information, the uncertainty, you could see being turned into an argument for why states really need the kind of ultrasound laws that help women understand and feel less uncertainty or grapple with anxiety in these testing and abortion decisions. So not to end on a gloom and doom note, I've tried to paint the picture a little bit more darkly than maybe is warranted, but food for thought as we move forward in our conversations about this intersection. Thank you.
Can I put this down? I'm going to put that down as an accommodation of my short stature. Okay, so I am also going to pick up on some of the legal themes here. I'm a lawyer, and as Karen mentioned, and law professor here, and as Karen mentioned, I'm going to kind of focus on this intersection of healthcare or sort of real ambiguity or ambivalence we have about the place of abortion and reproductive healthcare more generally within healthcare. And I want to think about sort of some of the reasons for that and kind of various ways in which that's playing out today. I have sort of a series of more or less random reflections on that topic, and I think I'll just sort of throw them up against the wall and see what sticks, you know, like a bowl of pasta or something. So, the first comment, I guess, that I want to make about this issue is that I think it reflects a real uncertainty we have in this country about what is and isn't healthcare. We really don't, it's not a public conversation that we have had, and there's not a lot of consensus on what actually is healthcare, what is therapeutic, what is medical, what is medically necessary. You know, of course, within abortion, this is a particularly interesting problem to fit abortion within this framework because, as many of you probably know, in constitutional law, we've talked about the right to abortion within a privacy framework. We think it has, since Roe v. Wade, been considered an aspect of the right to privacy. And it really has never been talked about, at least within constitutional law, as part of a broader healthcare decision-making process or a broader right to make healthcare decisions autonomously. I think it's a notion, though, that should be kind of brought into the open. I think it's a way that we should view abortion and reproductive health care choices, and it certainly would make much more sense of this continuum from prenatal testing to abortion, and make more sense of this connection. And I think it also highlights a lot of what is really problematic about some of the kinds of laws that Rachel was just talking about in terms of ultrasound laws and other laws that are really invasive in terms of how they insert themselves in the relationship between the physician and the patient. As it stands now, there's just not a language for talking about that problem within constitutional law and the law of reproductive rights. Another observation about the connection between health and reproductive rights and abortion. As Karen was saying, alluding to, in international human rights discourse and globally, there's a much stronger connection between the right to health and reproductive health care. probably in the US, because for a number of reasons, I'm sure, and I'll just speculate that one of them might be, well, first of all, that we have never had a real right to health here, and that in the US, our healthcare system has been so much more privatized and decentralized than in many other countries. We just haven't had to make that connection to think about how we really conceive of health and what it includes and healthcare. But now, as I would also like to kind of chime in and suggest that under the Affordable Care Act, or I guess even liberals are allowed to call it Obamacare now, I gather, so I can call it Obamacare. Concepts like essential health benefits and medical necessity are still left largely undefined. Now, as Karen pointed out, there are certain categories that have to be covered, for example, by insurance plans under the new federal law. But as some of you may have been following this controversy, the Obama administration, essentially realizing how potentially explosive it would be for federal law to define what is an essential health benefit, basically decided to completely punt the issue to the individual states, who in turn are expected to essentially defer the decision to private insurers, to follow the lead of private insurers in defining what is health care, what is essential health care, and what is medically necessary care. So not that this was necessarily the wrong way to go, and it was certainly a politically astute way to go, but again shows how sort of uncomfortable we are with any move to define or have a conversation about what is health care, what does it include. And of course, you had to be living under a rock if you weren't paying attention to the uproar over the Obama administration defining contraception as health care, right? And mandating its coverage. And this real interesting, again, dichotomy in the discourse over those who were saying this is an assault on religion, and then the Obama administration, Health and Human Services folks saying it's about health care. This is health care. We had a similar controversy here in Ohio in our 2011 election. A ballot issue passed that is a constitutional amendment to the Ohio Constitution that's called the Healthcare Freedom Amendment, that is one of these anti-Obamacare laws that basically says, we don't have to, you can't compel anyone to buy insurance. But it's written very broadly to say no federal, state, or local law can basically compel anyone to buy insurance or prevent anyone from buying insurance or compel anyone to buy health care or prevent anyone from buying health care. So this passed, this crazy, which is crazy for all kinds of reasons, but passed overwhelmingly in Ohio. And then immediately after it became part of the Ohio Constitution, the legislature went back to work passing anti-abortion laws and passed a ban on, for example, insurance for abortion under the new state exchanges under the Affordable Care Act. And when some of the some of the pro-choice groups raised the point that, look, you just passed a constitutional amendment saying you can't prohibit the sale of health care or health insurance. You just passed a law prohibiting the sale of health insurance. What was the response by the supporters of the Ohio Healthcare Freedom Amendment? Abortion is not health care. Abortion is not health care. And Ohio needs to pass a law saying, or incorporate findings into their law that abortion is not health care. So we can see how this is becoming a more and more, again, sort of salient issue, I think, with the Affordable Care Act. At the same time, I think, though I personally take the position that reproductive health is essential health care, I think we're kidding ourselves if we don't acknowledge that, to a large extent, defining what is healthcare and what is essential healthcare is a morally and politically fraught endeavor. That it is almost always intertwined with issues of conscience, of what is a good society, what is for the good of society, and not to mention the fundamental moral question of how we allocate, what is the proper allocation of resources, limited resources. Like healthcare within a society. We can't pay for everything. What are we going to pay for? Whether the we as insurance companies, whether it's publicly funded programs. And in that context, I think it's really interesting to think about how providers, particularly providers of abortions, have kind of moved from being, again, a theme that Karen brought out, from being sort of guardians of morality for society and deciding when an abortion is and isn't appropriate, the sort of old pre-Roe, right, incidentally pre-really bioethics model, to providers as individuals with consciences, but still, again, making conscientious decisions about what healthcare is and isn't appropriate. Finally, I've got the yellow light, so I will just make a couple of points about another relationship between abortion and healthcare, which is that the Supreme Court has really recognized a relationship or a right of women to protect their health specifically in the abortion cases, and that's what's really fascinating. At the same time that there's this distinction, there is this really strong recognition, starting with Roe and even, through Carhart, although it's gotten watered down a lot, that even if the fetus is viable, women have a right to choose abortion to protect their health. They have a right to protect themselves against significant health risks. The problem is, again, what that means has never been well defined. The case law hasn't defined it. Legislatures generally don't define it either. And there's increasing pressure on that issue, too, and on that definition. And specifically, one really controversial point right now is whether or not it includes mental health, whether or not health risks include mental health risks. And this is often, if there isn't a specification for fetal anomaly in the law, this is often how providers will get in under that exception for post-viability abortions when there's a serious fetal anomaly, will be an understanding that it's necessary for the woman's health. But legislatures are becoming increasingly aggressive about excluding mental health as an indication for later abortion. So I think I'm flashing. So I think I will stop there and leave those. See what sticks on the wall. Thank you.
To sleep and shut down. Yeah. I don't have to log in. Mm-hmm. Okay. CW, yeah. There you go.
Good morning. It's good to be here. I want to begin, like everybody else, for thanking the organizers whose names I've known I haven't always met yet, but I've been so happy to meet Jessica and to meet Ruth in particular. But this is like old home week for me, too. I spent 8 years at this university and really got my start in bioethics here from 1982 to 1990, when I went to the University of Chicago, whose image is behind all of my slides. And I've really enjoyed meeting people that I didn't even know were here, like my friend Vim Rosenthal over there, and Nancy Johnson, and, well, Eric, you came and went since I was here. So I really want to thank the organizers. When I got the email message, I thought to myself, well, unlike Barbara, who considers herself old, I was officially retired 12 years ago when I reached 65. And seeing, people here that I haven't had a whole lot of contact with. I was even surprised that anybody remembered me, to be honest. But it's nice to be remembered, and it's really been just great to meet old friends. That's right. I could tell you stories about that, too. Clairol doesn't tell you how to go back. Anyway, I want to make a disclaimer at the beginning that I am not a lawyer. I do have in my immediate family both a doctor and a lawyer, and a lot of relatives who are lawyers. They're loaded in my relatives, but I have nothing against lawyers in general. However, the difference between ethics and the law, I think, is an important one for us to identify. With all the most liberal laws in the world, in our society or in any other, women still have to make their own moral decisions. The law is relevant, certainly, but it's never adequate. And sometimes, as someone who marched during the 60s, sometimes, as a matter of fact, our sense of our own ethical obligations require that we confront those laws if we're going to be true to ourselves. Now, everybody here, and especially those of you who are practitioners, are very familiar with the diversity of people and their values. Doctors in those they treat, teachers in those they teach, patients, even patients with the same set of symptoms, with similar experiences. And in some ways, I want to kind of zero in on some of that diversity that I think has caused some real challenges in terms of the material that we've been talking about during this conference. Let's see, what do I press?
You can press an arrow.
Yeah, okay. I thought I'd begin with this quote. This is one of my favorites. I've done a lot of talks on reproductive technologies as well as, I call them fertility curtailment, fertility enhancement. And I love this cartoon because it makes it look as if baby making is pretty easy, but we all know that it isn't at all. And this conference certainly illustrates our realization that it's a lot more complex than this apparent recipe suggests. I used to sometimes substitute after this cartoon some of the huge number of acronyms that can be used when the ordinary recipe doesn't work. IVF, ET, I mean, there's a huge, you could have a whole slew of things. But the other thing that this cartoon does represent is one person really does all the work in baby making, all the hard work. And it also, at least in my mind, reminds me of an issue that, well, Annie and I got involved in long ago and have been trying for years to get across to other people. The fact that that fetuses never, ever exist without women. Embryos do once in a while, but only after women have gone through an awful lot of stuff to get them to exist outside of women's bodies. But fetuses themselves never, ever. Some of us have really tried, and we succeeded a little bit around the issue of maternal fetal surgery. But fetal centers, fetal interventions, that language, and not only the language, the conceptions that fetuses are treatable and exist apart from women's bodies is still pretty prevalent, and it just never, ever happens. Okay, you can have stillborns. Okay, they're not fetuses, but they're stillborns. Extrauterинely, we don't have fetuses anymore. Okay? So that little thing reminds me of it. Now, when I was put on this panel for post-test options, I was thinking to myself, wow, we're going to hear about all of the improvements in tests. Not just numbers of tests, conditions that can be tested, degrees of invasiveness, lots of variables. Lots of things have changed there. But the post-test options have not really changed all that much. I added to this slide just this morning because after listening yesterday to, especially to Dr. Driscoll's account of the early invasive, I mean, that early invasive just leads to decisions about another test, and then another test, and then another test. And even when we get to the final test, the only one that can be done, or the only one that is done, even when we get there, we're not necessarily in a situation of certainty at all about what the ultimate results are going to be. Maybe for most of the anomalies we can be pretty specific, but for a lot of other things, even when we say, all right, as far as we know this is the case, it's only as far. And beyond that, I think we all know, no matter what is done out of whatever motivation to ensure that a newborn is as healthy as can be, disabilities, many disabilities arise at parturition, have nothing to do with genetics. And the great majority of disabilities for people who live in the world with disabilities are caused either at parturition or in accidents that happen later in life. So, but with that in mind, and with thinking more about that notion of disabilities that a number of speakers have talked about, an issue that has arisen for me sort of more poignantly in the last, I don't know, 10 years or so. I get involved in a disabilities course once a year at our place. And as a feminist, as somebody who explicitly identified myself as a feminist in print when our second daughter was in utero, and she's now 37, I've come to recognize more recently the challenge faced by anybody who champions women's choice around what has been called the disabilities critique. And that's what I'd like to address, as uncomfortable as it sometimes makes some of us feel. There are still pretty limited post-test options if we talk about that final test, after which no more can or will be done. And these are the basic options. There's the avoidance of pregnancy. That's if you do PGD, if you do prenatal genetic diagnosis. There's the initiation or continue, if you've done, because we can, I think, I don't know if people here want to, but we could talk about prenatal testing as extended to the in vitro status. We could even talk about it as testing gametes if we want, I suppose. But the decision to initiate or continue a pregnancy is there, regardless of whether the embryo is in vitro or in vivo. We can make decisions about whether we, and it's always both the woman and the fetus who might undergo treatment following a positive diagnosis, say, of a disability, or we can terminate. And if we're talking about in vitro embryos, we could dispose of the embryos. That's another possibility. Now, what are the reasons for these, I should have changed this word, post-test choices? Well, one obviously is the desire to know about and prepare for a specific offspring, one about whom we know something through this test. And the other is a desire to avoid parenthood of a specific child, one about whom we know this thing or set of things. And the most prominent example, of course, is one with a specific disability or the probability of a specific disability. Now, what are the problems with continuing or initiating a pregnancy after a positive test for disability? Well, there are undoubtedly going to be real challenges to a child born with a disability. There are going to be real challenges to the parents of that child, and there are real challenges, and I'm using a kind of neutral word when I say challenges, to society in general in terms of the care that might be necessary for that child. There's treatment that, at least in utero, is impossible without risks to the woman and the potential child. I mean, every case of maternal fetal surgery, as we insist on calling it, involves real additional risks, in particular the risk of prematurity. So people who even undergo that treatment are inviting risks that would not otherwise be there if they decided not to have the surgery. Annie and I first got acquainted on that issue of maternal fetal surgery many years ago, and it's still one that while techniques have improved, they certainly haven't reached a point of avoiding additional risks through those interventions. Now, what about support for post-test termination? Well, obviously, this facilitates healthy and desired births. It increases the options of pregnant women or the potential parents. It reduces the costs to individuals or to society in general of raising unhealthy or unwanted children. And then again, there's the routineness of the practice. I'd love to talk, but I'm not going to have time, a little bit more about the Buck v. Bell case and what I was challenged to in responding to someone who talked about that case years ago at a Florida law school. He took the last words of the decision, of Holmes's decision in that case, 3 generations of imbeciles are enough. And he said, in light of the history of prenatal testing and termination that has become so acceptable, what have we been saying? We said that was eugenics, but are we saying now 3 generations of what are not enough? And that really evoked a lot of thinking on my part. So against post-test termination, we know all of these, that it undervalues embryonic or fetal life, that it introduces avoidable risks to the woman and healthy embryos or fetuses, and that it facilitates termination for non-medical or trivial reasons. Eric alluded to this yesterday. I mean, you can terminate for other reasons, and in the advent of all the genetic tests that we can do in the future, there are going to be more and more grounds for terminating, for reasons of enhancement or for facilitating births. Already? No. That's because I gave you all that stuff at the beginning. The Disability Rights Critique for Termination of Disability. I will skip through my analysis of the expressivist argument, as it's called. It's really an important argument, and it's one that I guess I'm going to say I believe is valid. Valid reasoning doesn't necessarily lead to true conclusions. The truth of the conclusion, even with valid reasoning, depends on the truth of the premises. And the premises, see, I'm going to skip a lot here. I have to. This is the argument. The discrimination against people with disabilities is unjust. That's a true premise. It is unjust, right? The second premise, termination to avoid disabilities in offspring, expresses, that's why it's called the expressivist argument, discrimination against people with disabilities. That's a questionable premise. And with a questionable premise, we cannot draw a certainly true conclusion, even with valid reasoning, okay? That's what I'm saying there. Now there are, and everybody here knows them, especially practitioners, and especially women who've made these decisions, a lot of non-discriminatory reasons why women choose to test and terminate for disability. And here they are, you know them. The lack of economic supports, responsibility to those already born. I can't help but think of Carol Gilligan and her arguments around that issue. Pressures from others, could even be doctors. And this is the point that Adrian Ash makes again and again, ignorance of what it's like to live. Oh, no, wait a minute, I'm sorry. The ignorance of societal contributions and the quality of life. That's right. Adrian Ash makes this comment a lot, that women who make these decisions are not given enough information about what life with this disability is really like. I was going to offer and analyze a different argument, but I'm just going to tell you about it rather than put it down here. It's the argument that's based on the obligation that women who decide to continue their pregnancy are obligated to do as much as they can to ensure that the birth of their future child is as healthy as possible. I mean, I drank milk during my pregnancies. I never drank it at other times. I really didn't like it. I'm sure if we asked any of you women who have had kids, you really worked at it. I mean, you did a lot of things that you might not otherwise have done if it was going to help you have. Now, aren't we obligated? We've sent our kids to pretty good schools, not only to do what's necessary for their health, but to try and do as much as we can to ensure their health. That's an argument that kind of supports the rejection of the disability rights critique, or because it also supports the distinction between embryos and fetuses and persons with disabilities, it becomes, that argument, that part, becomes both a liability and a strength of the argument, depending on your point of view. I think, just kind of draw this to a close since I'm going to have to do that, I think it's pretty clear that many pregnant women terminate after a positive test for disability for non-discriminatory reasons. I think the society keeps discriminating because it doesn't give them the supports that they deserve and that they need, but that doesn't mean that individual women do. And it's clearly the fact that many pregnant women support just attitudes and practices towards people already born with disabilities. To get back to some of what Debbie talked about yesterday, in order to really have free decisions, and Karen, you were alluding to this, that these would really be choices on the part of women, we'd have to have a different society. We'd have to have one where the stigmatization of the disabled really wasn't so prevalent. We'd have to have one where the opportunities for support really were there for women. We don't have those societies. We don't have those things, and in the face of the lack of them, we don't have fairness. I wanted to conclude with this because I just like this cartoon. The little girl got an F in sex, and she thinks that may really be bad. And sometimes it does lead to certain difficulties in life. But the term F can also stand for other things, in particular in terms of what we've been talking about a little bit. It stands for fairness. And in terms of what we would like to see in society, and we would like ethical decisions as well as regulatory support speak to, is fairness, not only towards women, but towards people with disabilities. Thank you.
You don't have slides on your screen. Thank you.
Good morning. My name is Donna Patno. I'm a nurse midwife and I coordinate our fetal care center at the Cleveland Clinic. Not a week goes by really that I don't meet a family somewhere through practice where there's some kind of an ethical, legal, moral healthcare conundrum. And turning around and trying to choose a case for this today was actually pretty tough. I considered talking to you about a family I just worked with, prenatally diagnosed with a baby, and I call it a baby, not a fetus, because my families call it a baby. I'm not going to change my terminology. I'm going to use what my families use. Baby with trisomy 18. Third child, they were completing their family. They wanted this baby. Baby had trisomy 18. He had protested at abortion facilities. They're sitting in my office considering terminating a pregnancy. How do you counsel them? How do you help them? Thought about telling you about a family who just had been diagnosed. Their baby had multiple congenital anomalies. The amniocentesis results were normal. Baby had a lot of problems. Care provider wasn't able to help facilitate continuing care, whether that be termination or continued care for the pregnancy. What did they do? How did they make decisions? Instead, I'm going to tell you about a case that still makes me shake my head when I think back, and I question some of my pieces in the puzzle. Other providers, our ethics that came into play, and even some of the moral decisions, definitely some legal decisions in this one. This was a 35-year-old married couple. She was a nurse, had taken time and worked in a neonatal intensive care unit. She was pregnant with twins, 2 healthy kiddos at home, doing well. 21 weeks, she had an ultrasound. She had some vaginal bleeding in pregnancy. And when we looked, everything looked okay. There was placenta previous and bleeding. Okay, we can deal with this. Both babies looked completely healthy. One baby had a little extra amniotic fluid around it. See it a lot. What does it mean? It was very hard to say. Baby did look healthy. However, in the consideration and the due process of going through counseling, we had to say this is sometimes noted with certain chromosomal abnormalities. We can't tell you which ones. We can offer you an amniocentesis. It's your choice. She chose an amnio at 22 weeks. So we did an amniocentesis at 22 weeks, had fish ordered, so fluorescent in situ hybridization ordered. We get that back in about 2 days from the amnio. Baby A was our concern. Baby B's came back as normal female. Baby A came back as uninformative. I've never gotten that. Kind of sat back and looked at it and went, okay, now what do I tell her? So the physicians chose to say it's uninformative. We have to wait for the entire amnio to come back and tell you the karyotype. So that was at 22 weeks and 0 days when we did the amnio. The fish was back at 22 weeks and 2 days. 23 weeks and 2 days, she ended up back in the hospital with a vaginal bleed. We're watching what was going on. She also had pneumonia at the time. 23 weeks and 4 days, so 2 days after the hospitalization, we found that the baby A, actually had something called diploid triploid. Majority of the baby's chromosomes, as far as we could tell, were normal female, 46XX. There was a subset and a small percentage of the cells that they were looking at, about 10% of them, that was triploidy, which was 69XXX for this child. We didn't know which cells within this baby's body contain these. We didn't know what part of the body these may have impacted, but we knew that there were normal cells, but we also knew that there was this small amount of abnormal cells. What did it mean? We couldn't tell her. Huge gamut of what this could be. This child could be relatively unaffected. This child could also have significant and substantial delays. We laid it out, gave her options. A maternal fetal medicine specialist sat down with her and said, here are your choices. You can continue the pregnancy, you can terminate the pregnancy. So at 23 weeks and 5 days, so 23 weeks and 4 days, she found this out. In a day, she made a decision. She wanted a selective termination of the pregnancy. She wanted baby A terminated and baby B continued on. Problem was that she had placenta previa, she had just had a bleed, and she had pneumonia. It was not safe to do a selective reduction. Flipped the family out completely. Step back 1 day later. So we're now at 23 weeks and 5 days. State of Ohio, legal limit of termination at that time, we've changed, welcome to Ohio, was 24 weeks. So we would tell patients 23 weeks, 6 days is the last day we can intervene. 23 weeks and 5 days. She made the decision that her care provider, her OBGYN, was going to deliver the babies by cesarean section, both of them. We can't do that for one, so both babies had to be delivered. With non-resuscitation of baby A and full resuscitation of baby B. Baby A was the baby with the abnormal karyotype. She didn't want a handicapped child, but in the process, she was delivering this other baby, and this was scheduled for 24 weeks and 2 days to deliver this other baby and save it. And make sure she didn't have a handicapped child. Yeah, which is exactly, all of us involved, I think our eyeballs were this big and our hearts were all going, because not only were there legal ramifications, there were family ramifications, ethical, moral, social ramifications of this decision. So that was 24 weeks and 0 days. It was decided she would deliver by cesarean section in 2 days. And our care provider had scheduled it. Ethics came into play at that point. Our ethics committee sat down with her. 2 of us sat down with her to try to figure out what was actually going on with this family. How did they come to this decision? Did they understand the legal issues that were implicit in this decision? And what this decision meant for that otherwise healthy child? Because if we were doing something to A, in this case, we were also doing something to B. So we sat down and talked with them, and the family's biggest concern was they didn't want a handicapped child. They really didn't consider the thought of perhaps doing what we call comfort care, so carry the babies to term, and then really just keep that baby comfortable for A and do everything for B. Problem was, and I had to be honest with her, is doing comfort care solely for A didn't mean that A would die. At this point, we didn't see an anomaly with A. We saw an abnormal karyotype and nothing else. The baby was otherwise healthy structurally, as far as we could see. We couldn't tell her how this baby could act, learn, function otherwise, but anatomically, this kiddo was okay. And the other option was to adopt the baby out. There are lots of families who would very happily take this baby. No, that wasn't a choice for her. She didn't want that. Her only choice, she felt at that point, was to end the pregnancy with full resuscitation of B and standing by for A. Ethics committee met that night, and we felt that any patient with a decisional capacity has the right to refuse any therapy, whether it's life-sustaining or not. They have that right. But our question was, did that patient have the right to compel care of her care provider? Did she have the right to tell her care provider, you will end this pregnancy. I'm now fearful, I'm scared, I'm emotionally distraught. You need to end this pregnancy. You need to do comfort care and non-resuscitation of A and full, as we call it, the full court press for B. We did understand that the patient has the right to self-determination, but we really had to consider, could that patient compel care? We also had to decide whether or not it was okay for the decision she was making for A, what was that impact on B? And her avoidance of wanting a handicapped child, she was now putting onto baby B the likelihood of having a healthy, non-handicapped child, and pardon my use of that word, that is what the family used, being born at 24 weeks and 2 days. This child had a 50% chance of dying and had greater than an 80% chance of some kind of morbidity. So we knew that this child had significant implications for later on with a birth at 24 weeks and 2 days. So the ethics committee said, no, you can't deliver now. It's 24 weeks and 2 days. It's illegal. This is termination of pregnancy. Should a medical indication for delivery come up, that's okay. Well, about 6 days later, her placenta abrupted, and we did end up delivering the babies it was 25 weeks and 2 days. We did not resuscitate baby A per the family's request. We did a full resuscitation on B. B went to the NICU immediately. A went into dad's arms. 50 minutes later, baby's been hanging out there. It's now hypoxemic and hypothermic, so it's cold and it hasn't had enough oxygen. He decided that baby B needed to be resuscitated. Chromosomes run again, and the family would then make a decision once the chromosomes were back again to decide whether or not to discontinue care for baby A. 10 days later, chromosomes were back, and the family chose to remove life support. There's a case to consider.
You mean baby A?
Baby A. Baby A, we discontinued. They asked for discontinuation.
What happened to baby B?
Baby B continued on. Baby B is now in significant physical and occupational therapy. There are developmental delays, and I think there are some hearing concerns for her as well.
Okay, we'll take about 5 minutes of questions before our break, please. So if our panel and our speaker, if you'd like to, please remember to come down to the microphones to ask the questions.
In my kind of rush to think about this,
No, I'm up here again. But I have a comment and I guess a question. But first, I guess my comment is everybody in the United States kind of looks at Afghanistan and says, oh, isn't this terrible? Look, they've got this holy book and they're going to have Sharia law and they're going to impose all this on the rest of the population and take away rights, especially of women. Come to the United States. We have our own Taliban, right? We have a holy book. We have their interpretation of this book, and we're going to try to make these things into law. And I guess my question is, where is the separation of church and state? Where is that, I mean, in our,
Can I say?
I mean, that's supposedly in our Constitution, right? And I guess I'm confused. What happened to that?
Okay, the lawyers.
This actually gives me an opportunity to say something more clearly, which is, in thinking about state interest, we're really thinking about when can the state regulate, and when can it do it counter to the liberty interests you would have, procreative, paternal, whatever. But interestingly, these state interests aren't explicitly religious, but it gives me an opportunity to clarify that some of these collective aggregate concerns are really important, and we might be interested in thinking about carefully what role society should play for what values and ethics, religious or otherwise. Religious, we may say, that's not our system of government, but other ethical concerns, we don't want to target disabled populations and marginalize them. We don't want sex selection that distorts a population ratio of men to women, and we might, as a population, come to some types of consensus around regulation that has a collective impulse that I don't mean to demonize entirely, but I think your question gets at something more fundamental to my thinking, and I think our panel's thinking, is that we don't have a language to talk about those issues in those more nuanced and complex ways that doesn't either get derailed as very issue-specific or pigeonholed or otherwise. And so one of the things in mentioning sex selection in my own presentation, I just wanted to clarify that, some of the impulse behind these laws are the conversations we should be having about these twins, right? So just to say that quickly.
But don't you think the conversation gets derailed because you're talking on two different platforms? If you're talking on a religious platform, it's black or white, what's right and what's wrong. And if you're talking on a scientific platform, there are theories, hypotheses, and gray areas. So don't you think it's not just the language?
There's something in the middle, too. I mean, it isn't one or the other. I mean, there's a lot of respect for the pluralism in our society.
Yeah, right.
And that
No, I think,
Roe versus
That's really
Wade
important.
happened. There's an interesting collision course between the disabilities movement, Roe versus Wade, and science. And they're on an interesting collision course and the disabilities issues can really be separated out from the religious issues. They're often intertwined with each other, but I think that the conversation about this 24 weeks and the 25 weeks and, is it really very artificial or not, that once it comes out of that vaginal or either cesarean or whatever, we change the language.
Yeah, now we have a newborn who has all legal rights.
And, for some,
Semantics.
either with strong religious beliefs or just other sorts of things. It doesn't always have to be grounded in religion. It's murder, and the fact that it's sitting inside some woman's womb is...
Makes it different.
Yeah, doesn't
Makes
make
it-
it distinct. I hear you, but the analysis in the courts, anyway, has not been on freedom of religion.
Right.
I mean, it's a different jurisprudence altogether.
Right. And I guess my next
But
question.
I was just going to say, but as a political matter, there is no separation. As a political matter, there
Yeah,
is.
right.
Under legal norms, there is.
Politically, you
But
do
politically,
whatever.
there's not. And even in constitutional cases, it's not black and white.
So, thank you for a great panel. My question comes out of some of the material we just heard. I'm not sure this is necessarily the best panel for the answers, but I want to put it out there on the table. So some of the laws that you alluded to require healthcare providers to say or not say certain things to their patients. Most egregiously, a link completely without evidence between abortion and breast cancer, for example. So I'm not a physician, I'm probably not reading the right literature, but I'm not reading, I cannot imagine in a million years that I as a physician would say something to my patient about her health that I know is incorrect. It is not possible for me to imagine that. And I'm waiting to hear about what physicians, what kind of civil disobedience, what kind of refusal, what kind of marches on the state legislature. And
lawsuits.
I guess I'm reading the wrong stuff.
There have been some lawsuits, in fact,
Yeah.
under
Well,
the
in
context
Florida,
of
they
freedom of speech. They
Yeah.
haven't, the last one wasn't successful.
No, there was
Well,
a
no, although they,
in Florida where
They're mixed.
yeah.
the was that pediatricians were enjoined from asking patients if there were guns in their homes, which is one of the things Americans.
But there actually have
Yeah.
been some challenges in these abortion state statutes
Right.
about being told what to say or what not to say, you know, about the discretion of providers when they're providing care. I think what you're really raising is an interesting philosophical, societal, whatever question about, you know, that there is a role that these statutes play to make a point in society, but they're never in reality happening. And so your question is, how verbal does the physician or the healthcare community want to be about that? Because for many, not only is it taking away their discretion, but it's a question of malpractice.
Right.
I mean, and it's very rare. There are a few exceptions of other state statutes where they'll tell doctors what they have to say before a woman has a biopsy for breast cancer. You know, so we have a little bit of analogy, but not much. This is unique, and I just think it's probably ignored. I don't have the empirical data to back it up, but it'd be interesting what some of the doctors.
Yeah, I mean, courts have struck down, those kinds of requirements when they've found that they are actually a requirement to give inaccurate information. I mean, the problem is sometimes they're written sort of
Vaguely.
right, and courts read them as saying, well, use your discretion, say whatever you think is the accurate statement about that, or something. Like, you don't have to say there is a link between abortion and breast cancer. You just have to say, whether you believe there, whether medical knowledge supports a link or something like that. And in South Dakota, actually, where there was a law that said, you have to tell the woman that she's terminating the life of a whole separate living human being, they upheld that. But then they did strike down the part that said that they also had to tell her there was a link between abortion and poor mental health or suicide, or it was something along those lines. So they do, I mean, there's a line, it's not a very comforting one where they draw it, but.
And in practice, the sad thing is that, or the good thing is, I don't know which way to look at it sometimes, is that we're all allowed our opinion. And as professionals, I can choose to just not heed the newer information that may have firmly refuted the breast cancer termination of pregnancy link. So therefore, it doesn't really exist. And when I talk to that woman, I can say, there is some literature out there talking about your risk of breast cancer being increased and having that termination of pregnancy. I don't have to say the rest. And that's the danger sometimes in prescribing what it is that providers have to say, but also at totally leaving that door open. You hope that everybody comes in with their professional obligation first and speaks the truth. It's not that that person is not speaking the truth when they omit things, it's just that sin of omission, as I call it.
Actually wrap it up and let us discuss this a little bit in the break so we get a break in and don't fall too far behind. But thank you very much to our panel and our speakers. If you could please rejoin me in here at about 10:20, we will start back up with our final session. Thank you.